exceptionally qualified leadership. We have become a trustworthy organization in the industry. We have machines have exceptionally qualified leadership.
Imaging
We have become a
like
trustworthy
Sven,
organization in the
Catigram.
industry. We machines have exceptionally qualified leadership. We have become a trustworthy organization in the industry. We machines have exceptionally qualified leadership. We have become a basic organization in the industry. We machines have exceptionally qualified leadership. We have become a basic organization in the industry.
Hello and welcome everyone to this yet another session of Radiology Journal Club, a new initiative by Indian radiologists. This is the fourth in series journal club which we are conducting online. The one which we started was with the neuroimaging session, followed by breast imaging by Dr. Shilpa Lal. And then we had an excellent session by Dr. Amey Kulkarni on body imaging, where he discussed one interesting article and then two interesting cases. We are thankful to all the key organizers of these events, specifically Dr. Gauri Ahuja for all her efforts, Dr. Sanjeev Mani sir, Dr. Deepak Patkar sir, Dr. Jignesh Thakkar, Dr. Shailendra Singh sir, and Dr. Mamta Patkar ma'am. So the main intention behind these radiology journal clubs was that every month we meet together online and discuss some upcoming new article and kind of revise important highlights on these articles, because we know that subspecialty is the way ahead. And in our busy day-to-day schedule, we might not get time to read these articles, these advances, and to discuss about them. So we make an endeavor to call one expert who has dealt with these things in practical life and take advantage of their experience and make use of all these updates in our day-to-day practice. We are thankful to our key sponsors, Bayers and Phantom, for their support for all these initiatives and events. And they have shared important updates about their events upcoming as well as their products. So I would request all of you to go through them. So today's session is on musculoskeletal imaging, and we are thankful to Dr. Chaitali Parekh, who agreed to be with us today. She is a young and dynamic radiologist with key interest in musculoskeletal imaging. She'll be discussing one important article and after that two interesting cases. Dr. Chaitali is consultant dealing with musculoskeletal radiology with Pulse Chain of Diagnostic Centers and Newtech Diagnostic Center, Kalyan, Mumbai. She has completed fellowship in musculoskeletal diagnostics and intervention radiology at Innovision Imaging, Mumbai. She has received Dr. R.N. Goel Gold Medal for Best Paper Presentation on MSK Interventions, was also selected as one of the best speakers at REDX speaker competition of radiology review courses. And she is quite famous on YouTube channel of Indian Radiologist with over 5,000 views on almost all her videos and updates. And thank you, Chaitali, for joining us today. And we're looking forward to this session from you. We welcome you, and over to you, Chaitali.
Thank you so much, Mitisha, for this wonderful introduction. And I'm extremely sorry if my voice is a bit weird. I'm having a bit of a sore throat, so please kindly bear with the harsh voice for today.
Everybody is having the same issue now.
And at the outset, I would like to thank Indian Radiology for this wonderful opportunity. I know it's an immediate post-Christmas time and everybody would be in a vacation mode. So I'm not going to keep it too long for today. The article that we are going to discuss is on shoulder instability. I'll just share my screen. I hope everyone can see my screen.
Yes, we can see your screen.
Okay, thanks a lot. So today's article is on shoulder instability, predominantly the concept of on-track and off-track morphology. This article is not a very recent one. It's a couple of years back. But this concept has actually gained a lot of importance in today's life, and not everyone is aware of this concept. But I'm sure in your day-to-day practice, all the shoulder surgeons particularly would be really, asking for whether is there an engagement or is there not an engagement, because once we tell them what status it is of the shoulder joint, the surgery plan changes. So now they routinely ask for this stuff because they know that as radiologists, we can give them the accurate information. And so it is really important on our part to understand that how we are supposed to take these measurements so that the information that you provide to your surgeons is an accurate one. So in today's session, what we are going to discuss is first we look at the article, which is from the AJR journal. Then we will come back and I will discuss with you about the concept of on-track and off-track morphology, how to take these measurements accurately, and then we'll go on to look at some of the cases. So let's just go for the article first. Okay, so I think all of you can have a look at this article. The link was also shared with you before. Even if you've not gone through the article before, that's absolutely fine. You'll understand the entire gist of the article today. And whenever you get time in the future, you can go back to the article and have a look at it. People who don't do these instability MRIs often, it is difficult to keep a track of it. So whenever you get such a scan, make sure you go back to the article, look at the images on how to take the measurements, and then you can go ahead reporting the MRI. So this article is on MRI evaluation. The key is that it is about MRI evaluation of bipolar bone loss using the on-track, off-track method. And this article was written by Giftopoulos et al. And it was published in October 2015 in the AJR journal. So as I told you, it's a relatively older article, but it's one of the very good articles on this particular topic. So that's the reason why I've chosen it. The objective of this study was to determine whether the simultaneous MRI evaluation of Hill-Sachs lesion and glenoid bone loss by the use of on-track, off-track method can be used to predict engagement during arthroscopy. So the thing is that it is easy to evaluate the bone loss and the Hill-Sachs on a CT scan, but we don't want to radiate the patient to another CT scan. So how can you accurately measure these measurements on an MRI? The study is about that. So they took 75 patients and who had a prior history of anterior shoulder instability. And these patients, they got a preoperative MRI done for the shoulder, followed by arthroscopy in the same institution. And they checked for the engagement the data about the engagement that they got on a preoperative MRI. And they compared it with whether the shoulder was actually engaging during surgery or not. So as per the results, they predicted 13 out of 18 engaging lesions correctly. So it's a pretty decent sensitivity of 72%. And 58 shoulders which did not engage, which means that they were on track, they correctly predicted 51. So again, it's a pretty decent specificity. The accuracy was 84.2%. The positive predictive value was 65%, and the negative was 91%, which meant that if you rule out, or if you say that this person is not going to engage, that is going to be that percentage is higher. So to correctly predict that the shoulder is not going to engage is more than to correctly predict that the shoulder is going to engage. So what is this concept of bipolar bone loss? Bipolar bone loss means looking at the Hill-Sachs lesion and the glenoid bone loss together. Now, for people who are complete amateurs, I'll just give you a brief. So whenever there is a shoulder instability, we all know that usually the shoulder dislocates anterior-inferiorly, as a result of which the posterior superior humeral head is going to hit against the anterior-inferior glenoid. And because of this impaction, there is a impaction fracture or an impaction injury in the posterior superior humeral head, which is called as the Hill-Sachs lesion. And anterior-inferiorly, because of the continuous impaction, either there can be an anterior-inferior glenoid fracture, which is called as the bony Bankart or the osseous Bankart, or because of recurrent instability or recurrent anterior dislocations, there is bone loss in the anterior-inferior glenoid, which is called as the glenoid bone loss. Now, till today, meaning till recent times, the two injuries were assessed separately. But with this concept of bipolar bone loss, now it is emphasized that there should be a simultaneous evaluation of both Hill-Sachs lesion and the glenoid bone loss and their relation to assess engagement of the joint. So there are two concepts for this on-track, off-track morphology. The first one is the glenoid track. So glenoid track is that, so assuming that this is my glenoid articular surface, this is my glenoid width, right? So not the entire width is in contact with the humeral head when the shoulder is in abduction and external rotation, which is somewhat like your ball throwing position. So this is the common position where you are in the end range movement of the shoulder and the shoulder is going to dislocate. So the humeral head is going to come anterior-inferiorly. So if this is your glenoid articular surface, then you should just understand that, sorry, just one sec. Yeah, so if this is the glenoid articular surface, the entire glenoid width is not coming in contact with the humeral head. So the key thing is that it is the 83% of the glenoid width is what is going to come in contact with the humeral head. So whenever we are calculating the glenoid tract is nothing but 83% of the intact glenoid width, which is important in the measurements of on-track and off-track. Similarly, in the Hill-Sachs lesion, so besides Hill-Sachs lesion, there is another concept called as the Hill-Sachs index, which I'll come to a bit later. So what happens is whenever the Hill-Sachs lesion is smaller than the glenoid tract, means that if this is my glenoid tract and my Hill-Sachs lesion is smaller than the glenoid tract, it is going to fit within this glenoid. And in that condition, there is decreased risk of engagement and instability. So if my Hill-Sachs is smaller than the glenoid tract, it is less likely that the shoulder is going to engage. But if my Hill-Sachs is larger, so if this is my glenoid tract and my Hill-Sachs is this big, then obviously there is some instability in this region and it's going to dislocate. So this is what is the concept of on-track and off-track. Now, when can you get the shoulder to engage? So when there is a large Hill-Sachs lesion, when there is a large glenoid bone defect, or when it is a mild to moderate sized bone defect at both these locations. This third concept is really important, the third point, and we'll look at its examples in some time so you'll understand it better. Now, previously a study was done where they used CT to evaluate the Hill-Sachs lesion and glenoid bone loss along with 3D reconstructions. But this article is particularly concentrating on how we can use a 2D MRI. So getting a, if you take a CT scan, you can, because it's a 3D thing, you can actually rotate and get the exact glenoid articular surface. But how you can use a 2D MRI to get those accurate calculations from an MRI, this article is about that. Now, this is what we were talking about. So if the Hill-Sachs index or if the Hill-Sachs lesion is smaller as compared to the glenoid, you can see that it is stable from both ends and it's not going to engage or dislocate. Whereas here, if you see, the Hill-Sachs is way larger as compared to the glenoid. So here it is not supported, and at this juncture, it is going to dislocate out. So we've discussed this. I'm not going to go in details about materials and methods and everything. I'll show you how we need to take a scan once we finish this article so as to get the accurate measurements. We'll just go down first. So again, what I've explained you, Hill-Sachs lesion is a region of cortical impaction along the posterior superior margin of the humeral head. Glenoid bone loss is the percentage and size in millimeters, which is best assessed by the best fit circle method. Now, what is this best fit circle method? So let's come back to these images. So you can see this is an MRI of the patient, and you can see the exact glenoid articular surface, the end face view of the glenoid. So this is the glenoid articular surface. Now, the best fit circle method states that you need to draw a circle on the glenoid articular surface such that it is going along the posterior and inferior aspect of the glenoid articular surface. So the circumference of the circle should lie on the cortex, on the posterior and inferior cortex of the glenoid. Now, when you've drawn this circle properly, the idea is if there is no glenoid bone loss, the anteroinferior glenoid cortex will lie along the circle. So the circle will overlap on the anteroinferior glenoid cortex if there is no glenoid bone loss. In this patient, if you'll see, this is your circle. And if you'll see, the glenoid cortex is over here, right? So you can see there is this red line which is drawn. So this red line is actually the width of the glenoid defect. So your cortex is actually going like this. And this is actually the length of the defect, which is because of the glenoid bone loss. So you need to get this dimension. And the second thing is the diameter of the circle. So the diameter of this circle is actually the diameter of an intact glenoid, which should have been in a normal patient. Right? So this is how you use the best fit circle method. We'll look at more examples for this. And the second thing is the Hill-Sachs lesion. Now, Hill-Sachs lesion is very well assessed on an axial MRI image. The important thing to understand is there are two concepts. So when we give the length of the transverse dimension of the Hill-Sachs defect, that is called as the Hill-Sachs lesion. Another concept is Hill-Sachs index. Now, Hill-Sachs index, if you'll see, whenever we look at for the on-track, off-track method, the thing that we need is the Hill-Sachs index, which is the length of the Hill-Sachs along with a bony ridge. So if you see that the Hill-Sachs is extending till this line, so the orange line is your Hill-Sachs lesion. After that, there is a small intact bony bar between the Hill-Sachs lesion and the infraspinatus insertion. So the length that we need is from the infraspinatus insertion up to the medialmost margin of Hill-Sachs lesion. So that entire length is the Hill-Sachs index. In some patients, you may not have this bony bar. In some patients, if the bony bar is present, in order to calculate the Hill-Sachs index, you need to add this length of bony bar to the length of the Hill-Sachs defect. That is your Hill-Sachs index. Okay. Again, we'll look at these examples. For now, just understand everything, what it is. We will look at more examples so the concept is more clear. So in this particular circle, the larger or the diameter of the circle is nothing but what I told you. That is the length of or the width of the intact glenoid. This will label as capital D, D for Delhi. And the small length, which is nothing but the glenoid defect because of glenoid bone loss, this will label as small d, small Delhi, right? So the glenoid track is 0.83 of the glenoid diameter minus the glenoid defect. Now, why 0.83? Because as I told you, whenever your shoulder is in abduction and external rotation in the extreme position, 83% of the glenoid width is going to be in contact with the humeral head, not the entire glenoid articular surface. So for calculating the glenoid tract, this is important that you multiply the glenoid width with 0.83 or 83% of the glenoid width. So this is how you'll get your glenoid tract. We've already discussed how to get the Hill-Sachs interval or the Hill-Sachs index. So it is the width of the Hill-Sachs lesion plus the width of the intact bone bridge between the infraspinatus or the rotator cuff attachment and the lateral margin of Hill-Sachs lesion. Just remember, the bone bridge is not present in all the patients, but if present, it should be added to the Hill-Sachs index. So lesions were considered engaging or off track when the Hill-Sachs interval or the index exceeded the glenoid tract, as I told you. And if it did not exceed, they were non-engaging or having an on-track morphology. Another patient, so this is another patient where you can see they've drawn the circle as per the best fit circle method. The diameter of the circle is 27.2 millimeters. If you will see, the anteroinferior glenoid cortex is not overlapping with the anteroinferior aspect of the circle. So this length in transverse dimension, or actually the AP dimension, is your the small d or the width of the glenoid defect. And this is the transverse dimension of the Hill-Sachs lesion. Now, if you see in this patient, this is your infraspinatus attachment, right? So you can appreciate this entire thing is the infraspinatus tendon footprint. If you use non-fat saturated images, the work becomes even more easy. So I'll show you how to measure this on a non-fat saturated image as well. So this is your infraspinatus footprint. If you see, the Hill-Sachs lesion is reaching up to the infraspinatus footprint. So this particular patient is not having any bony bridge. So the Hill-Sachs defect the Hill-Sachs defect length is same as the Hill-Sachs index for this particular patient. We go back to the previous one. Here you can see that there is a small bony bridge which is intact. So in this case, the Hill-Sachs index is slightly larger than the Hill-Sachs lesion. Okay, so now let's just come to the discussion. So we've already discussed the results part before in the beginning, that they had an accuracy of 84.2%, which is a very good one. They predicted 13 out of 18 patients correctly as having engagement, and 51 out of 58 on-track lesions were correctly predicted. So why all of this is important? Why do you need to discuss about engagement and stuff like that? As I told you, engagement can happen in 3 scenarios: when your Hill-Sachs is larger, when the glenoid bone loss is more, or both of them are average size. Now, if the shoulder is engaging repeatedly, by just doing a capsulolabral repair, which we usually do for an anterior instability. So anterior instability, you have an anteroinferior labral tear, capsulolabral tear, which is also called as soft tissue Bankart lesion. So the surgeon goes in and repairs the labrum, and along with that tightens the capsule. But if there is a lot of bony defect, despite this soft tissue repair, the patient is going to have persistent anterior instability. So the surgeon needs to take a step ahead and perform some extra more complicated surgery. And if we tell them that such a surgery is needed, the surgeon can accordingly plan for it. So whenever there is a marked glenoid bone loss, they usually go for a procedure called as the Latarjet procedure or the coracoid process transfer, where they take the coracoid process out and put it in the defect of the anteroinferior glenoid. And that's how they increase the width of the glenoid articular surface. For a large Hill-Sachs lesion, they either do a humeral head bone grafting to fill in the defect, or they do a remplissage. Remplissage, I have just written over here, so we'll just skip on to this part. So remplissage is a procedure where the infraspinatus tendon and the adjacent capsule is used to fill up the Hill-Sachs defect. This is a bit of a complex procedure, so the surgeon needs to be well prepared for it. So now, what were the advantages of this study? First thing is that it has shown that even if you do the simultaneous evaluation of Hill-Sachs lesion and glenoid bone loss on a 2D MR images, you can get accurate results just like 3D CT or 3D reconstruction images. So you do not need an extra CT for these patients. Compared with the CT, MRI always helps to evaluate the soft tissue injuries as well. Like if obviously there is going to be a labral tear, there is going to be a capsular injury, which you cannot evaluate by just doing a CT scan. So MRI is like a one-stop shop where you can evaluate everything. Also, and on an MRI, evaluating the Hill-Sachs interval is more accurate because you can see the infraspinatus insertion. So on a CT scan, you cannot really appreciate the infraspinatus insertion correctly. And so if whether there is an intact bony bridge or not is difficult to evaluate on a CT scan, but that is very well assessed on an MRI. So your Hill-Sachs index is more accurate on an MRI. And also it will help to evaluate if there is any bone marrow edema, whether the injury is acute or subacute and stuff like that. And just remember, even if there is a bone marrow edema, it is not going to influence your measurements of glenoid tracking and Hill-Sachs index, particularly if you use non-fat saturated images, because the edema won't be seen separately. So this was all about the article. It's a bit complex thing if you're going through it for the first time. So in order to simplify it, I have made a PPT slide out of it so that you understand how to measure everything. So the summary of the article, what are the terminologies that we've used is one is bipolar bone loss. As I told you, previously we used to assess Hill-Sachs and glenoid just separately, but now we need to assess both of them together. What is the relation between them? And that is nothing but bipolar bone loss. On-track lesion is where the Hill-Sachs lesion is going to stay on the glenoid tract and it will not engage. So in short, your Hill-Sachs index is smaller than the glenoid tract. Off-track lesion is where the Hill-Sachs index or the Hill-Sachs lesion is going to go out of the glenoid tract, and hence it will be unstable and it's going to dislocate or it's going to engage. So which means in practical terms that your Hill-Sachs index is larger than the glenoid tract. So again, just an animation for you to understand that how things happen. So when can a shoulder engage? So this is one patient who has a decent enough or a small to moderate size Hill-Sachs lesion, not a too large one, and there is no significant glenoid bone loss. You can see the articular surface is decent enough. Now here, if you see, the Hill-Sachs lesion is larger. There is no significant glenoid bone loss, but the Hill-Sachs lesion is larger. And if you understand here, it's stable at both the ends, even in the extreme position. Whereas here you'll see that there is meaning there is no support on this end of the Hill-Sachs lesion. And so what will happen? It is going to engage or it's going to dislocate. So whenever you have a large Hill-Sachs lesion, the shoulder can engage. Again, the same, this is just a normal one, a small Hill-Sachs lesion for an example. This patient, if you'll see, the Hill-Sachs lesion is of the same size, but now this patient has a large glenoid bone loss. As a result of which, again, if you appreciate here, there is no support to this Hill-Sachs lesion in the extreme position. And again, it's going to engage or dislocate. So a large glenoid bone loss will cause it to engage. And the third condition, which is a more important one and is more commonly seen in routine day-to-day life. So individually, if you look at this, you'll say this is not a very big Hill-Sachs lesion. Individually, if you look at the glenoid also, you will say that it's not a very big glenoid defect. So individually, if you see at them separately, you will feel that the shoulder will not engage. But when you actually do the measurements, and when the surgeon will try to engage the shoulder in the OT. So usually in the OT, they try to engage the shoulder and see whether actually the shoulder is engaging or not. He will get engagement in this patient. Why? Because you can see that despite the fact that this is a moderate sized Hill-Sachs and just a moderate sized glenoid, but there is still the Hill-Sachs is getting unsupported over here, and this is going to result into engagement. So that is why the concept of bipolar bone loss is important, that is assessing both of them together. So how do you calculate the glenoid tract? We've seen this. So the glenoid tract is 0.83 into capital D. Capital D is your intact glenoid diameter, and this is the width of the glenoid defect. And to note, just remember that even when you calculate the percentage glenoid bone loss, it is the same small d and capital D, which is used for the percentage glenoid bone loss. So once you get these two measurements, your job for glenoid is completely done. You'll get all the measurements out of it. And how to get them? By using the best fit circle method. So now let's look at it. What is the best fit circle method and how to get the exact image? So because your MRI is a 2D MRI, it is very important that you get the exact section. you'll only get one section on the sagittal image where you can see this entire articular surface of glenoid. If that section is not appropriate, you will never get accurate measurements out of it. Then you'll have to go back, get a CT done, or call back the patient and get a sagittal image again. So just make sure, please tell your technicians to plan the sagittal image very accurately in a patient with shoulder instability, because it's that one particular image which will give you all the information. And if you don't have that one image, your information is not going to be accurate. So here you can see, we all know that the sagittal is planned along the glenoid articular surface. So it should be actually along the anterior inferior glenoid, so that you get this exact glenoid end face view. And if you can see, my line is going just at the level of the glenoid cortex. So, and if you correlate this axial image to the sagittal image, so this is of the same patient, you can see that there is some hyperintense structure over here. So first thing, both of these are proton density images, non-fat saturated, because non-fat saturated usually gives a better evaluation of the bone cortex and everything, because your fat marrow is going to be brighter, your cortex is going to be hypo. So you can actually identify the cortex very well on a proton density non-fat saturated images. So here at this level, you can see that this is your labral tear, right? So you can see yahan pe the labrum is very much intact. There is no fluid signal between the labrum and the glenoid. Here you can see there is a discrete fluid signal between the labrum and the glenoid. So this is an anterior-inferior labral tear. Along with that, if you can appreciate, there is this gray zone over here. So this gray zone is the glenoid articular cartilage. This black line is the humeral cortex. The gray zone above that is the humeral articular cartilage. You can clearly appreciate that there is a defect in this anterior-inferior glenoid, a chondral defect. So this is actually nothing but a GLAD. GLAD is nothing but a glenoid labral cartilage. So basically the cartilage is also avulsed off along with the labrum. So this particular chondral defect over here, you can appreciate it even on the sagittal image. So this hyperintense signal, what you see is nothing but this chondral defect. Now coming back to the best fit circle method. So you can appreciate this particular cortex over here, and you can see this entire cortex is going like this. So you can clearly appreciate the glenoid articular cortical margin. Here you can see this is your tone labrum. There is a gap between the glenoid cortex and the labrum. So this is an anterior-inferior tone labrum. And this black thickened structure is nothing but your intact posterior labrum. So once you have a decent, meaning a very good end face view of the glenoid, you can do the measurements easily. So what you do is, this is your glenoid, you draw a circle. Now the circle should be such that it's going, it's along the cortex, along the posterior and inferior cortex of the glenoid. Okay. Now just remember, while taking the measurements, one thing which you have to keep in mind is this, it should be a complete circle and not an oval. Because if it becomes an oval, again, your measurements are going to be wrong. How to make sure that it's a circle? So this is I have used it on an Osirix. Similar thing, you can also get it on the radiant viewer as well. So whenever you draw the circle, you're going to get the width and the height dimensions. Okay, so just make sure that the height and the width are same. Only then the structure is going to be a circle and not an oval. So once you know that both of them are same and this is your circle and it is going along the posterior and inferior cortex of the glenoid adequately, the next step is to look at the anterior-inferior glenoid. Now here you can see that the circle is actually overlapping the anterior-inferior glenoid cortex. So there is no glenoid bone loss in this patient. First thing. Second thing, for the glenoid tract, you need the diameter of the circle, which is nothing but 2.7. You can directly take it from these measurements. So the diameter of the intact glenoid is 2.7. Since there is no glenoid defect, the small d in this patient is 0. So the glenoid tract is nothing but 0.83 of 2.7 centimeter. That is what is a glenoid tract. Now this is just a comparative image to show you that you actually get the exact same measurements between a CT and an MR. So this was the CT of the same patient. You'll see I've drawn a circle. Here also, my diameter is coming out to 2.7 centimeters. There is no glenoid defect. And the same thing I can reproduce on an MRI. So this is just to show you that you do not need a CT for these measurements. You can do it on an MRI accurately, provided you have the proper end-face glenoid view on a PD sagittal or any sagittal image. This is another patient. Here, even on just on eyeballing, you can identify that my posterior labrum is good, my posterior cortex is good. So glenoid has a pear shape, so it should have actually gone like this, but you can see that it's blunted over here. So there is some amount of anteroinferior glenoid bone loss. How much it is, we'll calculate. So this was my circle going along the posterior inferior cortex. And here you can see that it is not going along the anterior cortex. So this is my anterior cortex. And this is my length of the glenoid defect, or the small d, which I'm talking about. So this is the length of the glenoid defect. My capital D is the intact glenoid diameter, which you need not measure actually. You can directly get it from these measurements. So it is 2.7 centimeter. So this is my intact glenoid diameter. Again, just remember, it should be an exact circle and not an oval. If you make it an oval, your diameter, the length of the defect is going to be wrong. So this is that, and then you can just put it in the formula. You've got the small d, you've got the capital D, and you'll get a glenoid tract out of it. Now, as just a third example, again over here in this patient, you can see that on the CT, you can clearly appreciate that this patient has an anteroinferior osseous Bankart, or a bony Bankart lesion. But again, you can also appreciate it on the MRI. So you can see that this is my glenoid articular surface. You can appreciate that this is a bone piece lying over here. And identifying bone piece is more easy on a proton density image than on a, meaning a proton density non-fat saturated image, than on a fat saturated image. So if you look at it closely, even small bony Bankart lesions can be identified on a MR image if you have the proper sections. So this is my bony Bankart over here, which can be seen on the CT, which is just for your visualization. And here you can see that this is my blunted anteroinferior glenoid margin. So you can draw the circle and you can get the defect. Now, why have I put this example? Whenever you are calculating the glenoid tract for this patient, please exclude this. Exclude the bone which is broken out. Okay, so the surgeon needs to know that after you remove this bone, or without this bone chunk, whether the shoulder is going to engage or not going to engage. You can put it in the report also clearly that excluding the anteroinferior osseous Bankart lesion, the glenoid bone loss is such and such percentage, and the glenoid tract is this much. So you can actually make it very specific and clear on the report that you have not included the osseous Bankart lesion in the calculation of your glenoid tract and glenoid bone loss. So we have seen how to calculate the glenoid tract, which was the more difficult part. Now we'll look at how to calculate the Hill-Sachs index. So Hill-Sachs index, as I've told you, it's Hill-Sachs lesion plus bony bar between the lesion and the infraspinatus enthesis. So again, we'll just look at examples of this. So this is a patient with a Hill-Sachs index, with a Hill-Sachs lesion. And obviously your Hill-Sachs lesion, the dimension that you need for the Hill-Sachs index is the transverse dimension. That's why I've only shown you axial images. And as I told you, proton density non-fat saturated image will be more helpful in looking at the bone. If you take fat saturated images, there will be bone marrow edema. It is difficult to identify because your bone cortex, marrow, and infraspinatus tendon, everything is going to be in shades of black and gray. It is difficult to identify the exact bony bridge because bony bridge are not too long, they are smaller ones. And so a non-fat saturated image will be more helpful. So here you can see this is my Hill-Sachs lesion. And so while giving the measurement of the Hill-Sachs lesion, I will say that the transverse dimension of the Hill-Sachs defect is 1.1 centimeter. But this patient, if you see, this is the level where my infraspinatus enthesis is, right? Or the insertion is. So there is an intact bone between the infraspinatus and the medialmost margin of Hill-Sachs. The lateral margin of Hill-Sachs. And this length is nothing but the bony bar or the bony bridge. So my Hill-Sachs index in this patient is going to be 1.1 plus 0.7, which is 1.8 centimeter. While in this patient, if you see, the Hill-Sachs defect is actually extending up to the insertion of the infraspinatus tendon. So this patient does not have a added bony bar. So in this particular case, the Hill-Sachs lesion transverse dimension is going to be the Hill-Sachs index for the measurement of on-track and off-track. So I hope you've understood this concept of bony bar and how to find it. So just remember one thing, meaning what can you derive from this? the Hill-Sachs lesion, which is more medially located, meaning towards the humeral articular surface. So the region which is more medially located will have a larger Hill-Sachs index and is more likely to engage as compared to a same size of Hill-Sachs lesion, which is more laterally located towards the infraspinatus insertion, right? So the lesion which is more medial will engage more compared to the lesion which is more lateral towards the greater tuberosity. So let's just look at the cases now. Okay, so this is a patient. You can clearly see the Hill-Sachs lesion in this patient. So this is your proton density image, and what we're going to do is we're just going to come from top to bottom now. Sorry. Okay, so I don't want you guys to concentrate on the tendons and everything for now. Please just look at the labrum, the glenoid, and the posterior superior humeral head. So first we look at the posterior superior humeral head. So here, as you see, just remember, for measuring of Hill-Sachs lesion defect, or even for identifying the Hill-Sachs lesion, the key thing is that you need to look at the defect at the level of coracoid process. Okay, not below the level of coracoid process. So if you'll measure over here, this is not the level for a Hill-Sachs lesion. Even in normal asymptomatic individuals without any history of instability, this kind of flattening is normally seen at the level of infraspinatus insertion below the level of coracoid process. So if you have to identify a Hill-Sachs lesion, make sure to look at or above the level of coracoid process. So here you can see that actually it should have been a complete round structure like this. So this is how my humeral head should have looked like, but I can identify that there is this much of flattening over here, right? So obviously this patient has a Hill-Sachs lesion. Then we just go and at the level of so then at the level of maximum Hill-Sachs lesion, we take the diameter. We take the length of the Hill-Sachs defect. So here you can see that this defect is approximately 2.2 centimeters in length. Okay. And if you identify the infraspinatus insertion, so you can see that this is the level where my infraspinatus is actually coming and getting inserted, right? So it is at this level. So surely there is no bony bar in this patient. So the length of the Hill-Sachs defect is going to be the Hill-Sachs index for this particular patient. So this is how you go inferiorly, and this is your humeral head has been evaluated. Now we look on the glenoid side. So again, we are going to come down from top to bottom. So here, if you see, this is my superior most labrum. Okay, you can see that there is some linear signal over here. Superior labrum is best assessed on your coronal images. So here you can see that. So this is my level of superior labrum. So you can see that there is some tear that is beginning in the superior labrum over here. So there is a tear over here. And as you go further inferiorly, you can see that there is a tear over here. The posterior labrum looks okay. Further inferiorly, you can see that there is a tear over here. There is a tear over here. The posterior labrum looks okay. Okay. So till inferior most sections, you can appreciate the tear in the anterior labrum, whereas the posterior labrum is intact. So you have an entire anterior labral tear over here. Okay. And the posterior labrum looks good. So we assess the soft tissue Bankart injury. So we know that there is an entire anterior labral tear. Now, the most important thing is whether it's engaging or not. And for that, what you need is your glenoid tract. Now, for the glenoid tract, the section that I need is the glenoid articular. So you can see, I'll just go a step back. Okay. So here you can see this is my cortex, the glenoid cortex, very well seen. Above that, you can appreciate the gray glenoid cartilage, and then you have the gray cartilage of the humeral head. Now, the green line is actually the planning that was done by the technician. And if you see, it's exactly cutting at the cortex of the glenoid articular surface. And hence I can get this wonderful end-face view of the glenoid, just like what I would have got in a CT scan. Okay. Now, when you come inferiorly, okay, it is difficult to appreciate over here that there is a bony Bankart or a osseous Bankart. But you can surely identify that there is some blunting of the anteroinferior glenoid. So here you can see it's nice and pointy. Here you can appreciate that it's blunted out. And when you look at the corresponding sagittal image, you can appreciate that there is bone over here. So you can see that this is the cortex and this is a bony chunk over here. So this is so this is nothing but a bony Bankart, which is about 7 millimeters in length. And this is my end phase glenoid. So as I've told you, the glenoid has a pear-shaped appearance, but here you can see that it has been blunted out over here. So now when I take this circle method, okay, I'll just draw a circle and show you. So I'm going to draw a circle. Okay, so here if you can appreciate, so this circle is now it's properly passing along the posterior and inferior cortex of the glenoid. The diameters of both the width and the height is 2.7 centimeters. So which means that it's a proper circle. So my diameter of this intact glenoid should have been 2.7 centimeter, but it is not. And the defect length now over here is about 3.3 millimeters, or in short 3 millimeters. Okay, so you can just make the calculations. So you can just put it on the calculator and just say 0.83 of 2.7. So this is 2.2 centimeter, right? And so glenoid tract is 0.83 into 2.7, which is 2.2 centimeter minus 0.3 centimeter. So it's going to be 1.9 centimeter. So my glenoid tract in this patient is 1.9 centimeter. And I have already, I think I deleted that. So one sec, sorry. And my Hill-Sachs is approximately 2.2 centimeter. So in this particular patient, the Hill-Sachs index is larger than the glenoid. So it is likely to engage. So when you give this information that the Hill-Sachs is large and the glenoid bone loss is not too much, the surgeon knows that if the shoulder is engaging, he needs to go for a remplissage procedure, because the glenoid bone loss is not that much that he needs to do a Latarjet procedure in it. So if there is engagement even on arthroscopically, he'll be well prepared before the surgery for remplissage procedure in this patient. So this was one case. Let's look at I do have a CT of this patient just to show you the osseous Bankart. So this was the same patient, and you can see this was the osseous Bankart that we measured as 7 millimeters. And even on a CT scan, you can appreciate that it is actually 7 millimeters. So if you have that exact image, you can identify the osseous Bankart, smaller ones even on an MRI. This is my second patient. So again, we are looking at the proton density axial images. I'm going to pick up proton density images because, as I told you, for me, differentiating structures on a non-fat saturated image is more easier. So as we go from top to bottom, I told you at the level of the coracoid process, if you begin to see a defect, that is what is a Hill-Sachs lesion. Okay. Now here you can see this patient has a more medial Hill-Sachs lesion, right? So this, So this is my Hill-Sachs lesion over here. And the length of the Hill-Sachs defect is 1.1 centimeter transverse. And here, if you see, my infraspinatus insertion is this. So this is my infraspinatus enthesis, this entire line. Okay, so this is my infraspinatus enthesis. So what I have is an intact bony bar between the infraspinatus enthesis, up to the, so between the infraspinatus enthesis up to the Hill-Sachs lesion. So this intact bony bar, okay, is there. So now my Hill-Sachs defect transverse dimension is 1.1 centimeter, but my Hill-Sachs index is going to be 1.1 plus 0.7, which is nothing but 1.8 centimeters. So my Hill-Sachs index is larger. Why? Because the Hill-Sachs lesion, though it is a smaller Hill-Sachs lesion, it's a medially placed Hill-Sachs lesion. And such medially placed Hill-Sachs lesions are more likely to engage. Now let's look at the labrum. So we'll first get a coronal view. Okay, so here, this is my coronal view. And just to tell you, the previous image was that of a 3 Tesla, but this is that of a 1.5 Tesla. So you can see that with good quality images, with the proper planning, you can get very good quality images even on a 1.5 Tesla scanner. You don't need to do arthrograms and stuff like that to look at the labrum. So here is where I am in the topmost section, okay, here. And you can see that this place you can get some magic angle artifact in the posterior superior labrum, but here surely there is a labral tear which is beginning, okay. And here you can appreciate that there is a discrete labral tear. As you go inferiorly, here also if you'll appreciate that there is a tear even in the posterior superior labrum. So there is a tear here, and in fact there is a tear here as well. You can see this white line that's going through. And as you go further inferiorly, this is your intact posterior labrum, right? So up to the level of the equator, see here you can see the tear over here. So up to the level of the, or just above the level of the equator, even the tear is extending into the posterior superior labrum. And this is your tear in the anterior labrum. And this is again your tear in the anteroinferior labrum. And now what you can see is, this is the adjacent anteroinferior glenoid chondral defect. You can appreciate the rest of the cartilage very well. And as you go further inferiorly, you can see the chondral flap over here, right? So even on a coronal image, you can see this chondral flap over here, okay? So these are the chondral, this is the chondral flap, which is actually come out from this level. Now, you can see a toned labrum. You look at this anteroinferior glenoid, it's well rounded, just like a posterior inferior glenoid. So you don't see any obvious blunting of the glenoid. It's nice and rounded, okay? Here also it's nice and rounded. So from this, you can judge that there is no significant anteroinferior glenoid bone loss. By significant, I mean at least it's going to be less than 10%. So if a bone loss is less than 10%, the surgeon is not going to operate. If the bone loss is more than 25%, then they do consider a lethargic procedure. Between 10 to 25% is again it's a question of debate. Some surgeons will operate and do a lethargy after if it's more than 20%. Some can do if it's more than 15%. So depending upon whether shoulder is engaging or not, and depending upon what is their routine practice going to be, the percentage can vary. So it is best that the orthopods that you're working with, you get an idea from them that when is it that they actually consider a lethargic procedure between 10 to 20% cases, meaning to 10 to 20% glenoid bone loss cases. So here again, I'll just draw the circle quickly. Sorry. I'm just redrawing the circle. Yeah, so this is my circle, okay. Yeah, so now if you can see, I've drawn a circle which has a diameter of 2.8 centimeter, and it's pretty much going along the anteroinferior glenoid as well. So this person does not have a glenoid bone loss, and the glenoid tract is just going to be 0.83 of 2.8. Which is going to be 2.3 centimeter. And my hills, though it's a, in this particular patient, though it was a medially placed Hill-Sachs lesion, the Hill-Sachs index is coming out to be 1.8 centimeter, and the glenoid tract is 2.3 centimeter. So this is less likely to engage. So this is a on track or a non-engaging morphology. Okay, and just I would like to show you the CT image of this end phase glenoid view, just to show that it really did not have an anteroinferior glenoid bone loss. Now the third and the last case that we're going to look, this is also a 1.5 Tesla MRI. So you can see that you can appreciate the structures very nicely. So here you have a small Hill-Sachs lesion, okay, and at the level of the at and above the level of coracoid process, you can appreciate this Hill-Sachs lesion. This is going to be the length of the Hill-Sachs lesion. And you can clearly see that the lateral margin of the Hill-Sachs lesion is just adjacent to the infraspinatus insertion. So your Hill-Sachs lesion transverse dimension is same as your Hill-Sachs index. And so here you can see that you can appreciate that there is a tear in the superior labrum over here. Okay, this thing. So you can see that there is a tear in the superior labrum. And here on the axial images, you can see that the anterior labrum is torn, but the posterior labrum is good. And inferiorly also, you can appreciate the anterior labrum is gone and the posterior labrum is good. Now you can see that here on this image, there is a blunting. Okay, so this is my glenoid. in this particular image also, you can appreciate that there is this blunting. So it's going like this, and then there is a blunting over here. Sorry, there is a blunting in this part of the glenoid, right? So this part of the glenoid is well and pointed, posterior inferior, and the anterior inferior glenoid is blunted out. And if you go inferiorly, you can actually appreciate that there is a bony piece over here. So you can appreciate the cortex in this region. So this is a bony piece. And now when you look at the corresponding sagittal image, you can appreciate that this is the bony piece over here. And this is my bony chunk. So you can clearly make out this bony piece. And when you want to make take the diameter out for the glenoid tract, this is how you'll measure it. So just make sure what I was talking about is don't get a circle like this. Okay. So now you know that one is 3 and one is 3.6 centimeters. So this is an oval and not a circle. So just make sure that you get a proper circle. And don't over exaggerate. Don't make a bigger circle, because then you'll get a larger, meaning if I'll take a circle like this. Okay, so this is a circle. And if I take a circle like this, I'm going to get a glenoid defect, which is like literally 8 millimeters in length. But this is not the right way. The idea is that you should draw a circle just large enough so that it covers your posterior and inferior aspect of glenoid. So you need to adjust it and make it a bit small. Okay. So here this looks decent enough now. It's actually going in my posterior and inferior glenoid. And this is my level of the glenoid defect. So here I can just measure the length. So it's 4. So my glenoid tract is going to be 2. So this is 2.9 centimeter. So 0.83 of 2.9 centimeter is 2.4 centimeter. And then you're going to subtract 0.4 centimeter, which is the defect of the glenoid bone loss, or the length of the glenoid defect. So it's going to be 2 centimeters. So my glenoid tract is 2 centimeter and my Hill-Sachs index is 1.4 centimeter because there is no extra bony bar over here. And so obviously my Hill-Sachs is smaller than glenoid. And so this is going to be an on-track morphology. So with this, we've discussed the cases also, and we're almost through the session now. So today what we've discussed is what exactly is the concept of bipolar bone loss. How do we take these measurements? Just remember, CT is not needed for assessing engagement if a proper MRI planning has been performed. Hill-Sachs index evaluation is more accurate on an MRI because you can see the infraspinatus insertion very well on an MRI. That's it for today. Thank you. Merry Christmas, belated Merry Christmas. And if you have any queries, you can ask me.
Thank you, Chaitali, for this wonderful session which you took. And you have really simplified a very new concept, which looks very complex for beginners specifically. Yes. And yes, all of us who are reporting shoulders, the surgeon want to know all these measurements. So they specifically write it down that whether it is on track, off track, you have to give all those measurements.
Right.
So, and by articles, it's difficult to understand. Like if it is your first patient and you start reading the articles, you might miss very important points. So I would just remind this to everyone listening that all of this is going to be on the YouTube channel. So every time you are doing the shoulder reports, you can revise what Chaitali has just discussed on the YouTube channel and understand these important measurements. There are few questions in the chat box. So one is regarding the positioning. So is that ABER positioning required?
It's not required.
Not required. And one question is that if there is a discrete bony glenoid fragment, as you showed in one of the examples,
yes.
which can be reattached to the glenoid, is it necessary to describe on track, off track, or should we just mention as an avulsed bony fragment size and the surgeon can reattach it?
So you need to understand again, what I have told is that on track, off track is both Hill-Sachs and glenoid put together. Okay, there are cases where you have a large Hill-Sachs and no glenoid bone loss, yet it is going to engage. And in that case, the surgeon will have to consider remplissage. Yes, you need to give the size of the bony fragment. The first thing that the surgeon is going to consider is put the bony fragment back. But one more thing that you need to remember is these patients, they don't come immediately post-injury. These patients come, some patients will come after years. And that bony fragment has actually got remodeled and the surgeon cannot. So if you want to fix back a fracture, it's like a jigsaw puzzle. The edges should match. Once the injury is old and there is an osseous remodeling that has happened, the edges are not going to match, the surgeon won't be able to fix it back. In that case, he will take a coracoid and put it there so that he'll freshen out the edges and he'll put a coracoid process there. So you need to give him this for two reasons. One is if it's an old surgery, then he has all the details because he knows that he's not going to fix back that the bony piece back into the glenoid. Secondly, even after fixing back the bony piece, there is still a possibility that the patient may have engagement because the hill sacks could be very long. So it is always advisable to give it.
Thank you for taking that in details. And one more question is there, that can these all be used for reverse Bankart's defects?
No, this concept is not used for reverse Bankart's defect precisely because the surgery is not performed that way. So for a reverse Bankart, usually the surgeon does not go for a bony Bankart repair or stuff like that. So the surgery, we just need to understand that our radiology is a kind of a dependent branch. It depends upon what the orthopods are actually practicing in day-to-day life. We can do as many calculations as we want, but if it's not practically useful for them, we are wasting our own time. So if maybe in the future, they might come up with surgeries where they will start doing a kind of a Latarjet procedure, even for a posterior inferior, for a reverse Bankart, then yes, maybe we'll start doing measurements for them as well. But as of today, such surgeries are not done, so it's no point that we waste our time on.
Just one more query. So there is what is the proper time that the scan should be done, like after an event of shoulder dislocation?
So ideally, if there is an osseous Bankart, large one, the ideal thing is that it should be done immediately. Meaning just after the dislocation, when it's relocated back and the surgeon will come, the patient will come for the scan. The only disadvantage with an immediate scan is that you are going to assess the soft tissue injuries. You're going to exaggerate the soft tissue injuries because of the edema. So the capsular injury, the labral tear, you might over exaggerate a bit. But if there is no proper osseous Bankart lesion, then it is ideal that we do it, say, after 4 weeks when the soft tissue injury edema has gone down. So you can evaluate it accurately. But if there is a bony piece, then obviously you need to fix the bony piece back. So in that particular case, an immediate scan is going to be more helpful.
So thanks once again, Chaitali. And we have taken all the questions which were there in the Q&A box. So please do visit our YouTube channel for more of such informative videos. And this particular session is also going to be there recorded. So you can revise all these details. And please do use all these things which we discussed, on track, off track, and different measurements for your shoulder reports. That will definitely enhance the quality of your report and help your orthopods. So with this, once again, thank you, Chaitali, for your time. And in a very short notice, you agreed to be with us today. Looking forward to more of such sessions. And thank you, Dr. Amit, for your support and the entire technical things which you do for us. I would request you to please play the Sonobuzz video once again.
Just before that, thank you so much, Mitusha. And thank you, Indian Radiologist team. This is a very good initiative because you're right. I myself am a very horrible person for reading articles. I just cannot read articles, but this is really a good initiative to be up to date with all the new advances that are coming.
Thank you. So now all of you, please do register for Sonobuzz. We are coming back with the actual events and conferences. So it's time to rebreathe after all this 2-year-long pandemic which we had, with all those precautions, definitely. So with this, thank you all for being with us today, and let's see and meet all of us together in the Sonobuzz.